Good morning. Okay, I'm going to talk to you pretty quickly over the next half hour, 40 minutes, about some of the pediatric vitreoretinal diseases that we run into. And I'll start out with ROP, retinopathy of prematurity, originally named retrolental fibroplasia, because they thought behind the lens what they were seeing was a membrane with vessels in it. And actually, they were detached retina. They were looking at detached retina behind the lens. But the man who first described it is shown here, Dr. Terry. He was up in Boston. And you can see in his original article, which was under notes and cases, as you can see in the AJO, wasn't a long article. But the illustrations, I think, today even are remarkable because they're hand-done, and they simulate very well what we show in photography today. Now, how do I advance this? Which one?
The arrows.
Okay, I was hitting the wrong one. Well, I tried these first.
Stuck again.
Huh? I know this happened yesterday because I was sitting with Jack putting the lecture together, and he said Dr. Jager was having trouble advancing it. But you can see there is depicted here in the second one down on the left a stage 5, what we'd call stage 5. And you can also see scarring in the retina in some of the others, and that is pretty characteristic of what we can still see today. There's nobody back there, so. Where'd Bill go?
Well, you got to improvise for a while.
Just outside.
You have to shut it down.
Oh, God, I don't know how to do that. It's all right. As you can see, Terry did not get to be an old man. He died young of a heart attack. And my father always thought the reason he died was he was so worried about these babies going blind that it precipitated the heart attack. I don't really think that was the case, but that's what they thought. And it is a lifetime disease. All of these diseases I'll talk to you about are lifetime diseases. If not, we'll just go without slides. And we have gotten better. Obviously, the first thing that was incriminated was oxygen. And they were given high doses of oxygen to these babies to keep them alive. And that precipitated some of the ROP. Now, what we know today, compared to then, is that if they needed the oxygen to stay alive, it wasn't probably going to cause ROP. But the problem was they continued it when the retina started to mature, and that's when the neovascularization started. So the man who figured this out was Arnold Patz, who was down at Wilmer. Actually wasn't at Wilmer yet. He was from Brunswick, Georgia, and he was a D.C. general in Washington. And he was interested in neonates, and he was the one that figured out if you cut back the oxygen, there's going to be less of the retinopathy of prematurity. Now, one of the other key people who helped elucidate that idea was a gal in Australia named Kate Campbell. And she noticed that the children in the hospitals where patients paid for their care therefore got high concentrations of oxygen because it was thought that was beneficial, got more ROP than the children and the neonates that were in the poor hospitals where they couldn't pay for it. And the incidence was lower. So those two people really made, I think, the key discovery about what was going on here. We know today oxygen's a factor, but the big thing is birth weight and I would say gestational age. You got it working. Is it working? This one? Good, thanks. What I've done here is just show you on the left the painting from the original article by Terry, and on the right a picture of stage 5. Now this publication came out in 1952 in the Netherlands, and it had some very good illustrations. As you can see here, the depiction on the left is what we now call plus disease, but it wasn't called that back then. But it's been recognized since the early days of ROP as a bad sign. And in a minute, when we get to type 1 and type 2 and how often you examine these infants, I get confused about it all the time. It's stage 1 and stage 3, zone 1, stage 3. The big thing is that the word plus disease is in the description, there's trouble. So that has to alert you to the possibility that there's going to be something there. And then you see a photograph on the right side of the screen of plus disease. Now, as residents, you have malpractice insurance, all of you? Through Jefferson? And what company is it? Do you know? I asked the other day, and she told me, but it was something I never heard of. So good luck. But, well, I'm with OMIG, which is the insurance company of the American Academy, and I just had to renew it. And I was telling Mark that they have a questionnaire there. Do you screen ROP? So I don't screen anymore, but I do see them in consultation. So I put down that I didn't screen, but I thought, to be honest, I should tell them that I see them in consultation. Not only to be honest, but to protect myself. You know why? Because if one of the babies that's screened ends up in a lawsuit, they're going to sue every name that's on the chart. So I wanted to make sure that I was covered. Well, that opened a Pandora's box with the insurance company, because I said, you know, you just said screening, and I don't screen, but now you want me. So I had to take a test. They have a test that they give you if you're going to be dealing with preemies. I said, okay, I'll take the test, but I don't think that it's fair to say screening, and then if you don't screen, do consults. You better include that if you're going to be exposed. And this thing went all over the company and up to the top guys. And, of course, as in all companies, there are lawyers in there. And I finally met up with the one lawyer over the phone. And I told him, I said, what you're asking is really not fair. If you want to make sure that everybody is versed in it when they're looking at ROP, then it should be that you have to take this exam. If you screen, you have to announce if you consult, and if you treat. I mean, it didn't make sense to me. But anyway, I think they're going to do that. Having said that, it all comes to mind because of this slide. Does anybody know what these are? And did anybody attend the oncology thing last weekend? Because they showed these. And they were talking about fibroblascular proliferation, and that's what these are. They're called popcorns. And you can see even back in 1952, they were well recognized and documented in this picture. And so that's a pretty good sign that you've got active ROP that you have to pay attention to. They also can go on in ROP cases to form falciform retinal folds. You can see a drawing on the left and a picture on the right. They were pretty accurate in their depictions. Now, this is a terrible slide, and it's a terrible slide because there's a cataract. There's a cataract present in this one-eyed patient. And the question comes up, was ROP a new disease in 1942, or could it have existed earlier? What do you think? Think it just started in 1942? No. Okay. This woman had been born, you see, in 1999, she was 75. So I asked her how much she weighed, because even through the cataract, I could see this pigment here. And you can sometimes see that in babies who were premature, or people who were premature babies. She said, I weighed 2 pounds at birth. I said, that's amazing that you survived back then. She said, yes, they finally just sent me home from the hospital, and my parents kept me in a bureau drawer until I got heavy. I said, they left the drawer open, didn't they? Yes, they left the drawer open. So she had lost one eye from ROP in infancy, but the other one had done pretty well until she got this cataract. And the reason I saw her was a second opinion as to whether she should have the cataract out. Cataracts are a big feature of ROP. They usually occur earlier than you see in the normal population. So I looked at her and I said I thought she would benefit from cataract, and the cataract surgeon then went ahead and removed it, and she did do well. So I think this was not a new disease, but it was described. Now today we treat the ones that come to threshold, so-called, with cryo first. We did that in the 80s, but now it's all laser. And the cryo ROP study, which is often cited, I think today would have been done with laser. It was just that you didn't have a portable laser you could get into the nursery in those days. This is the zone classification. Zone 1, which you'll see is going to be the most dangerous, is a circumference with a radius twice the distance from the fovea to the disc. And that defines where the end of zone 1 is. Then with zone 2, it extends to the nasal aura, but you still have a temporal avascular zone. And then zone 3 is when it finally gets into that area temporally, close to the aura. Now, another way to look at zone 1 is to use the 25 diopter or 28 diopter lens. And if you put the disc at one edge of the lens, and you can see avascular retina at the other rim of the lens, you're probably in zone 1. So rather than trying to figure out, well, is that really twice the radius from the disc to the macula? If you can see the disc at one rim and the avascular zone at the other, it's probably zone 1. So this just states this, and it's in the outline, but the stages are also important. And usually in stage 1 you can read this for yourself, but again, down at the bottom, the plus disease, if you see that, and it's due to vascular shunting, so that the veins are enlarged and the arteries are tortuous in the posterior pole, that is a bad sign. Now, I showed you pictures of advanced plus disease, but it can be much more subtle than that. So one of the things that has to be looked at is there any tortuosity in the vessels? And that was one of the questions in the OMIC exam. They showed you pictures of ROP, and you were asked, is this mild, moderate, no plus? And the funny thing about it is you could usually identify if there was plus disease. But the funny thing about it was that maybe 4 years ago, there was a study done in which they circulated pictures of plus disease to so-called experts in ROP, and nobody could agree among the experts. But when they were just asking if there's plus disease, you could tell that. Treatment today is primarily laser, but there is a big thrust for Avastin. But there are no peer-reviewed studies yet that show there are no side effects down the road with Avastin. And I'm not saying I'm against it, but at the present time, as long as we've got a valid study with laser that shows it is effective with a very high percentage of success, I'm not anxious to use Avastin, especially since it's going to get into the other eye as well, and we really don't know what effect it could have later in life from affecting other vessels in these small babies. But the proponents of it are zealots. They really, and it does work, no question. Now, the other question about the Avastin is the dosage that they were giving, because they were giving the same dosage that we give adults with macular degeneration. And that didn't seem to make sense to me. So Ralph Biedl got me this, he had a slide of an infant's eye compared to an adult eye with a melanoma. And you can see that the volume of the vitreous cavity is much smaller in the infant eye. It's about a third. So we've now halved the dose of those that do get Avastin. A few examples. This is a stage 3 of fibrovascular proliferation right here in an avascular zone peripherally. And you can see the plus disease posteriorly. That certainly would be a candidate for treatment. And another example, and you can see how it's actually growing back on the vessels posteriorly. So these do respond to laser treatment, and many eyes are now saved that would have been lost. But using laser, are there any problems? Well, this is one problem. If you have an infant like this that still has a persistent tunica vasculosa lentis, it's sometimes hard to get through and see the fundus, and that might be a good case for Avastin. This has often been confused for neovascularization, but it's really just engorgement of the vessels. This was a picture, actually, when I took that exam, this was one of the pictures they showed. So when do you start examining? Well, the key thing is, obviously, the smaller the baby, the lower the gestational age, the more critical it is to get started looking. And what's generally recommended, if the gestational age is 26 weeks or less, the first exam should be about 31 weeks PMA. And that's what's followed. Most of the changes occur between 31 weeks and 45 weeks. And then you can see, this is in the outline too, how often you look at these children depending on the findings when you first look at them. Always are on looking more frequently than less frequently. But a pick, particularly in the zone 1s with stage 1 or 2, and I would add plus to that, there's plus, you ought to look every 2 to 4 days. This is the new classification with the early treatment retinopathy prematurity study. Used to be that threshold was when you had 5 contiguous hours of stage 3 plus disease, or 8 interrupted hours of stage 3 and plus disease, you treated. But under the new type 1, type 2, you can see what the indications for treatment are. And on the treatment side, it's only if you have stage 3 without plus disease that you can't miss that. You have to treat it. But with all the others, plus disease is present. When you decide to watch for progression, if you have stage 1 without plus disease, you can watch it. And 1 or 2 without plus disease, again emphasizing the importance of plus disease. Then next, after stage 3, you have stage 4A retinal detachment, where the macula is spared, subtotal, plus disease we've shown you, and cataracts, which certainly can develop, as you can see there. Now with the treatment, this is a zone 1 that was treated, Here's the macula of the disc, and you can see how posterior this comes. This boy was a twin. I treated the twin too. But look at the macula. You don't see the usual foveal pit. Now, that's not true in all, but you can see the vision's 20/40. He's -3 diopters myopic. And it is true that they can see well even though they don't have a foveal pit. Now, this was Paul Baker when he was a fellow here, did this study with me. And what we found was that the ROP babies had thicker foveas than did a control series. Just a diagram showing for the ROP babies, the fovea was about 150 microns, and for the ROP, it was between 200 and 250. We also looked at adult ROP eyes with myopia. As you can see, there were 43, and 39 were myopic. It's very common for these babies to grow up and be nearsighted. And in the general population, the incidence or prevalence is only 20% of myopia. But the average corneal radius, as you can see here, in the ROP was 7.4 millimeters versus non-ROP babies where it was 7.5, and that was statistically significant. So they have steeper corneas. They have a shorter radius of curvature and steeper corneas. And the myopia is not always axial. It's often due to the cornea. So they have shorter axial lengths and steeper corneas, but the ratio of the axial length to the corneal radius of curvature is the same as in the axial myopes, all of which means, from a practical standpoint, like, so what? But it is interesting that they're corneal rather than axial in most cases. I just put this in because it's, as you can see, a woman who weighed 2 pounds at birth, 32 weeks gestation. I first saw her when she was an adult and was one-eyed. She got a rhegmatogenous detachment in this eye, which we did reattach, and she ended up with 20/25 vision. As you can see, this is 2008, and there is an epiretinal membrane that's developed here. And here, March of 2010, she no longer has it. Her vision with the membrane dropped to 20/50. So I said, look, it's your only eye. I don't really want to do any operation here. You're 20/50, you can even still drive. She said, don't worry, I wouldn't let you do it. I don't want any operation on my only eye. I said, well, let's watch it. So this is what happened. This is the way it looked in April 2008 with this firm vitreoretinal adhesion. Then by October 2009, it had started to release, but it was still attached to that one area. This thing's not moving again. Bill, are you back there? Well, forget about it. I will tell you that it did go ahead and release. Now, maybe we'll just go ahead without the slides because he's not there, and I don't know. This apparently was happening yesterday, too. Let's talk about some of the other conditions where you have avascular retina in the periphery. Does anybody know any? Can you think of any? Well, one of the most common that we see is familial exudative vitreoretinopathy. Acronym for that is FEVR. And it has very often an avascular zone of retina, and about 70% of the time it's asymptomatic. They're full term, obviously, but when it is active and progressive, it's usually in infancy. And that's when you pick it up in the parents or a parent. It's inherited as an autosomal dominant and was first described in 1969 by doctors Scapins and Criswick. And they reported it at a meeting in Swampscott, Massachusetts, Swampscott Inn. I tell you, that was a broken down inn. And unfortunately, the next year after the meeting, it burned to the ground. But fortunately, there was no loss of life. It wasn't being used at the time. And they reported that then in '69. And ultimately, it was Gow and Oliver up in Canada who went ahead and did fluorescein on these people. And they're the ones that described the peripheral avascular zone. Now, you can see it without fluorescein, but fluorescein delineates it beautifully. The interesting thing is that in the asymptomatic patients, and one of the ways you diagnose this is to look, first of all, at the parents. And I had a woman just a week or two ago with her young son, and I wanted to look at her to see if she had it, and she said she didn't want to know. And I said, yeah, but I said, it's not about you. We got to find out. Well, then she said, okay, and she didn't have it. But anyway, these are the funny things that happen along the way. They don't seem to go on and form neovascularization like the ROP babies do. So most of the time you watch that peripheral avascular zone and it doesn't lead to any problem. In any event, as you get to be an adult, it can activate in adults, but it's less common than in infancies. And then you get exudative or rhegmatogenous detachments, either one. And that becomes more of a problem. We can do better now with vitrectomy on treating them. And it's a shame. I did have some slides show before and after. But the thing that's important is to know that fever is one of the conditions to be differentiated from ROP. Now, another one is incontinentia pigmenti. Have any of you ever seen a case of that? Yeah. Where'd you see it?
Peds clinic.
Where?
Pediatrics clinic.
Was it the dermatologists that were involved, or? Anyway.
Yeah.
What?
There were dermatologists involved. Dr. Levin as an IP patient.
Okay. So what did you see?
It sort of behaves like ROP. She had numerous surgeries, laser, cryo. Behaves very much like.
Was it a boy or a girl?
It was a girl. It's only women.
Why?
X-linked dominant.
Yeah.
Boys die.
Why don't you come up and give this here? I mean, I'm impressed. That's great. Yeah, it's X-linked dominant. The males don't survive. So you're dealing with female patients. And the youngest I've seen was 11 days old, had a big avascular zone, went on to a detached retina, and I couldn't get it fixed. This was before vitrectomy. The other eye, the other thing about all of these conditions, going back to ROP, fever, and I should have mentioned it earlier, and now IP, or incontinentia pigmenti, they can be asymmetric, with one eye much more involved than the other. And that was the case with this baby. The other eye had an avascular zone, but it seemed stable, and I was tempted to treat that avascular zone, but then I thought better of it, and I followed it. And as I followed this kid over the years, never had any trouble in the fellow eye. So she's done well from that standpoint. So it doesn't always follow the same treatment regimen as ROP does. I think you have to be selective, because there are cases of both fever and ROP where you might want to treat, but it's rare. And I think if they're not progressing to detachment, you can follow them, and some of them will do well. And the other interesting thing about it is that in these little girls that I've seen, the mothers often did not know they carried the gene for the disease. And a couple of them were one-eyed. They had lost one eye in infancy, and they had this history of a vesicular skin eruption, which is what they get. That's why the dermatologists get involved. And nobody had thought about, this being related to that condition. And yet, when you looked at the mother and did a fluorescein on her, you could see the avascular zone beautifully. And all of these conditions with avascular zones, I'll exclude ROP, have a fibrillar border where the normal vessels in the retina end and the avascular zone begins, sometimes referred to as a brush border. And these mothers will generally show that. And then on history, you can find out that maybe some other grandmother lost the sight in one eye and so forth. So that's another condition in which you can have avascular retina, but you don't always have to treat it. You just follow it. Now, another condition that I think is important, we're going to switch gears now. It won't be avascular retina. Let's talk a little bit about X-linked retinoschisis, because this is being X-linked affects males, and the mother is the carrier. Anybody know what the hallmark of the retinal findings is in this condition? X-linked schisis? Well, it's a stellate macular appearance, which is literally a schisis in the macula, but it has a stellate appearance. And that is the hallmark, but it's not true in every case. Deutman used to say it was true in 100% of cases. Is Bill back there?
Yes, please.
Could you ask him to come here, please? It's not, as I said, I've got examples where it's not true. But in any event, that usually pitches vision down to about 20/50 or 20/60. And then the other description of it was that you have dehiscences in the nerve fiber layer of the retina, usually inferior temporally, but it could be anywhere. This isn't working, Bill.
Yeah?
And I didn't see you back there.
Oh, yeah, that was...
If we have to reboot it, forget it. I'm just going to keep going.
All right, it's back.
Are you going to be back there now?
Sit back there.
Yeah, I would hope so. I'm going to run through these quickly because we covered all this stuff. I didn't cover all the cataracts. Often nuclear sclerosis occurs in ROP or posterior subcapsular. This is a woman, I operated on her retina when she was 11 years old. Now she's 51. She's getting a cataract. And this just reviews some results on things that we've seen in patients who've had cataracts. And I think that's in the outline, so I won't review it here. But remember, I did say that all of these diseases are lifetime diseases. And with ROP, you get exudation sometimes late in the disease. As you can see, December 2010, but after some laser on vessels that were leaking, it's getting less, but it can take forever to go away. Just other examples. This is the incontinentia venti, one case that we had, got the detached retina in the right eye. And the left eye, at the age 4 months, this is the one I was telling you about, had this hemorrhage in the retina, superior nasally of all places. And the macula, though, looked fine. Here she is 13 years later, still fine, with a large avascular zone here. And this is the mother. Remember I told you that they often didn't know they had it, but they have these looping vessels and then an avascular zone of retina. This is the youngest one I told you. I said was 11 days, 2-week-old female. And you have an avascular zone here. This is the eye that went on to detachment that I just showed you previously. And here's the mother and the aunt. Now, the aunt was single, and I told her about the inheritance of this disease, and she got married, and even so went on and had a child that ended up with incontinentia. The fever we talked about. This points out that 73% of patients have no symptoms. And the other thing that I didn't mention, and should have, is the temporal displacement of the macula that occurs with this disease. When you see that, you can't tell it from ROP. It's, they look, if I just showed you the dragging, you'd think it was the same disease. And here is avascular retina and fever with neovascularization. You can see it here. They're not exudates, they're neovascular tufts. This is a woman I saw about 32 or 33 years old, had been advised to have laser for lattice. So here's the quote unquote, would you laser that? First of all, would you laser it if it were lattice? I'll take that as a no, okay? Nobody's responded. But this was fever, and this woman didn't know she had it. And we got other members of the family, established the diagnosis. But here is the avascular zone, and so it was best that we leave her alone. This is a picture from Carol Shields of a patient with fever, and you can see out here the avascular zone. It's caused, oh, I didn't mention that. This is important. It's got 3 genes that involve it. But this was the SZD4 gene, sometimes we call the frizzle gene, which I always think it sounds more like a hair gene, but anyway, it isn't. And this is one of the families, and you can see there are several generations involved. In an experimental mouse model, you can see in the affected animal how the outer plexiform layer, inner plexiform layer, and nerve fiber layer, well, not so much the nerve fiber layer, but these two, there are many fewer vessels in the network than in the control eye. This little girl is one of the first I ever saw with fever. The first case I ever saw with fever, I didn't know it because it hadn't been described yet. And it looked like ROP, even though it was a full-term infant. And yet, the description of it came out about 2 years later. But the thing was, the parents said, what would happen with another child? And I said, well, it's not likely that you'd have it. Well, you know what happened. They had another child, and it did happen, and it was fever, which had then been described. But this young gal came in 5 or 6 years old with exudate and some beginning folding here. Well, that's when I thought it had to be treated, just like ROP. So I did cryo, and this is the way she looked several years later. I still see her. This was her grandfather's retina with the fibrillar border and an avascular zone, and her father had the same thing. And this is her fellow eye, the little girl's fellow eye. She had this one proliferative lesion here, which, see it here, which leaks on fluorescein. And several years later, it just dried up and left that stalk. And she still uses this eye, but she has 2 or 3 children now that are affected with the disease. And this shows just dragging of the retina in fever. Another case of fever with dragging of the retina and some sclerotic vessels and X-linked retinoschisis, and this is where we were. Here, can you appreciate the stellate appearance? You can see how it is a schisis right in the macula. Now, this raises another question of what's ethical to do. Maybe George Spaeth could talk about this in his ethics class. But this is a patient with, I think, nicotinic acid deficiency, in which they get a cystoid appearance in the macula. And it doesn't show on fluorescein angiograms. So Sabran and Koskis there in Paris They did ICG, and ICG does show the cystoid appearance. Now, I bring it up because this was a youngster. And the question is, do you put a youngster to sleep just to do a fluorescein angiogram that might show a change like this that isn't going to influence treatment or not? What do you think? How many would put the kid to sleep and do the fluorescein angiogram? Not fluorescein, ICG, which is not without risk. Nobody? Okay, one maybe. Now, schisis, I only did that because of the macular changes in schisis. This just shows some nasal dragging of the retina in X-linked schisis. And here's the macula. And although you can't see any stellate appearance there, there is still some schisis visible right in the macular area. This family, as you can see, has several affected members. And I remember I told you that 98% of the time they do have a stellate macula, but not always. Well, this is not always. This youngster had scarring and a staphyloma in the posterior pole, but did have X-linked retinoschisis. This is one of the dehiscences I described to you, and it is primarily the nerve fiber layer that you're looking at here. We used to say dehiscences are nerve fiber layer, but I think there are other layers we recognize are sometimes involved as well. They can also get through and through retinal breaks. This young boy is currently at Vanderbilt, but I followed him since he was a little boy. And you can see that he did develop a through and through break, which was lasered, because they do, about 4% of them go on to get retinal detachments. Now, Stickler syndrome, I didn't talk about, but you can see here the findings. They have radial lattice, perivascular lattice, very difficult attachments to fix, the flattened faces, myopic, high-arched palates. Here's the mother, aunt with a high-arched palate. Genu Valgum, where their knees turn in. And this is a family that I've had forever. You see where the arrows are, up near the top here. This lady is the first one that came in with a detached retina that I fixed. Then down here, her one son had a detached retina. And you can see all the involved members. And we tell them, you know, I mean, obviously they know the hereditary pattern, but most of them feel that they're not that disabled or they maintain at least one eye. Remember the mother I just showed you in the pedigree. This is what she looks like now, and it's very difficult to see through there because of the cataract. But you see all the lasers she's had. Now, this disease used to be confused with Wagner's. Has anybody heard of Wagner's? No, okay. I don't know the last time I saw Wagner's, and I'm not even sure the one case I did see was valid. Is somebody following me here? Okay. You got a few more minutes and I'll finish up? Or what time do you have to be out?
5 minutes. It's 8:25.
But several years ago, Irene Maumany, and she just went back to Switzerland, where Wagner was from. And if you look at the original article, what he described was mild myopia, optically empty vitreous cavity, and I neglected to mention that in Stickler's. That's an important clinical finding. And it's a different gene and chromosome that's involved. So she found the original members of the family that he described, which this is one. And they all show different things. I mean, there's no consistency. So you rarely hear of it. I can't think of the last time I heard anybody say anything about Wagner's. Fabry-Goldman, different story. But again, optically empty vitreous cavity, recessive inheritance. They get retinitis pigmentosa type changes in the retina, so they can have night blindness, but they also have proliferative retinopathy This is a woman who had a detachment repair, and she's done well. I still see her. PHPV, now some, including Mort Goldberg down in Baltimore, like to call this persistent fetal vasculature rather than PHPV. And the question is, you operate on them and you patch them and they still end up amblyopic. And I think the reason is because of this. This is just some pictures of Ralph's showing the hyaloid system, the fact that the ciliary processes are drawn in toward the center of the pupil. And here's a 12-year-old boy. You can see the unoperated eye. The macula looks pretty good. Over here, you can still see a little fovea. Here's the stalk of the PHPV. And a 6-year-old, and it's a little hard to tell from these pictures, so I can't make a good differentiation there for you, the macular hypoplasia. Toxocara, it's a 4-year-old girl. You can see the lesion. That's not her eye with the worm in it, but the falciform fold that she's ended up with, the other eye is okay. She went on to medical school at Jefferson, and I watched her as she was growing up, and I wrote a letter for her to the admissions and told her story because, you know, she probably on the basis of her record didn't have those great credentials. But I really pushed for her to be accepted because I knew she was going to do well. You know, sometimes you just know. And they took her, and she did do well. And she ended up marrying a cardiologist, and they're having a great time. This is the same patient, just a different view. Coats disease affects mostly males, average age of onset 7 years, but females do become affected. And the key thing is the exudate that it seems to gravitate to the macula, and you look in the periphery and you'll see these areas of dilated vessels that leak. And you can see this lower picture where the patient's been treated. She was a 9-month-old female, but as the exudate as the vessels are destroyed, the exudate goes away, and you see it's gone from the macular area, but her vision never got better than 20/80. The thing to remember about Coats, too, is that it can recur. I have one patient now that I treated when he was 11 years old, and I still see him. He's had 2 recurrences over the years, and you see the exudate. But they respond well to more laser. You just put it in there and it goes away again. But he now has had 2 stents in his coronary arteries, so that shows you how time flies. Vitelliform, egg yolk appearance. The EOG is the test of choice for diagnosing it, and if the gene carrier doesn't show it in the retina, doesn't mean the EOG won't be abnormal. It still helps you tell who the carrier is. High incidence of hyperopia in these patients. And remember that a certain number of them will have multiple lesions. They won't show up with just the egg yolk in the center, maybe not even show up with that, but they'll have these other lesions which really are lipofuscin under the retina. Here you can see in this angiogram how it blocks the fluorescein, and it is responsible for the white appearance here in the fovea. More illustrations. And Stargardt's, described by a German back in the early 1900s, caused by the ABCA4 gene. This used to be the way we diagnose it. You see this midnight fundus on fluorescein angiography, and they used to call it a beaten metal appearance in the macular area. Now we don't need to inject these children because with autofluorescence you can still make the diagnosis. How does it change? Well, here's a 1980 picture of a 13-year-old few pigment changes. 5 years later, it's got more involvement, and here he is recently, and it's pretty devastating change. So this is a progressive condition. This is a retinal dialysis. I only show it because this is a condition where you have lipofuscin underneath the retina, and it was Lucier, who's now retired, and Ralph Eagle who showed that. Because the dialysis I showed you was in a young man, 15 years old, who was killed on a motorcycle. And we got the eyes, and they were the ones that described the lipofuscin. One thing to remember is to advise them to wear sunglasses because it does slow down progression. UV blockers. RP, this is a variation called Laurence Moon Biedl Bardet. You see the extra toes. If you could see it, there are extra fingers here too. And then Leber's congenital amaurosis. There's a very good book I recommend, and then I'm going to stop here, called The Blind Doctor. And I get more from my patients than they get from me, but I had to give a talk a couple of Sundays ago on Helen Keller. And I mentioned that to a patient when she said, "What are you doing?" I told her I was giving this talk on Helen Keller. She was an ROP patient, now in her 40s. And she said, "Well, you need to read The Blind Doctor." And it's a true story. Have any of you read it by any chance? Well, it's a true story about a guy in Chicago whose parents are Polish immigrants, and it's a Jewish family, but that really doesn't play a role other than they were immigrants, probably from the same small town in Poland where you get second cousins marrying, and that helps with autosomal recessive disease, which is what Leber's is. And it doesn't tell you in the book what this man suffered from, but I figured it must be Leber's from the description. So these parents had 7 children, 3 of them born blind, and he was one of the 3. And he's a smart kid. He goes all through the top of his class, and he learns how to remember the lectures when he gets to college. You didn't have to go to college, I'm sorry. In school, and he puts it on Braille. But then he wants to become a doctor. This is in about 1892. And everybody tells him, "You can't be a doctor, you're blind." And he perseveres. And finally, the dean at the Chicago Medical School, now Loyola, said, "All right, I'm going to give you a shot." And he gets into school. Same thing. He aces all the exams. Anatomy, palpates things. The only thing he had a problem with was the vascular system, because that was on a chart. So he was talking to his mother, and she said, "Well, I crochet and sew a lot. Well, I use different size yarns. Get the chart and let me see it." So she mapped out the vascular system with different sized yarns. So he aced that too. But in those days, you didn't have to go to college. You went right from high school to medical school. And it was only 3 years. And in his last year, he's in the clinic, and this woman comes in, a young woman, and she's very short of breath and in agony and this and that. And they're all examining her, and they can't figure it out. And he said, "Well, let me listen to her." And he listens to her chest with his ear, not with a stethoscope. And he said, "It's her mitral valve. She's in congestive failure." And they didn't want to believe him because he was blind. But he finally convinced the professor, and they got her digitalis, and he saved her life. But it's got a lot of stories in there like that. But it was a good read. And he ended up dying when he was 34. He became very successful as a cardiologist, and then did a lot of lecturing. And he got to know Helen Keller. They knew each other because they were contemporary. But at his funeral, they said there were 5,000 people at his funeral. But I really enjoyed reading it. So I'll stop there, and maybe over the years we'll have, I don't think I left out much. Biedl's, Corneal, punctata albescens, Oguchi's disease. Do you know what Oguchi's disease, congenital stationary night blindness? This picture becomes this picture after 40 minutes in the dark. You know what that phenomena is called? It's Mitsuo's phenomena, M-I-Z-U-O. And this was a family from South Carolina. I actually, at that time, sent one of the residents down there to work them up. And then trauma. The only thing I'm going to say, because you know about trauma, you got a dialysis here, but notice that there's another one up here. When they're inferior temporal, they're often congenital, but I personally think that's the most common site for trauma, too. But this boy had gotten kicked in the eye with a soccer ball, and he had a dialysis in his other eye down here, but you see he's developed this one from the blow. So he had a traumatic detachment. Another long-standing macular hole. And I'll close. This, I promise, this is the last slide. You all know what these are. Can you see this here? Macular hole. 2-year-old girl. Smacked by the nanny. And that's how she got the macular hole. And I saw her like yesterday. Really hasn't changed. And her other eye's fine. And she's doing well in school. So anybody have any questions? And we'll stop there. I went a little over, but I think I got a little late start. So, well, I appreciate your coming. Thank you very much.